Thanks for joining us today. I'm Chris Wallis. I'm one of the urologic oncologists at the University of Toronto. Today I'm here with a really wonderful panel at ASCO 2025 in Chicago. We're going to talk a little bit about maybe the softer side of caring for patients with advanced GU cancers and how we approach that across our institution. So maybe starting on my left, Dr. Morgans, you want to introduce yourself?
Sure. Hi, everybody. My name is Alicia Morgans. I'm a GU medical oncologist, and I practice at Dana-Farber Cancer Institute.
Hi, I'm Brenda Martone. I'm a nurse practitioner. I work in GU Oncology at Northwestern Medicine here in Chicago.
I'm Jacqueline Brown. I'm a GU medical oncologist at Winship Cancer Institute of Emory University in Atlanta, Georgia.
And I'm Vadim Koshkin, GU medical oncologist at the University of California, San Francisco.
So you've already got a clue that we've got a really esteemed panel and some great minds thinking about how we take the data we see at ASCO and we actually take it to our patients and make sure that we can take our novel developments, our novel insights, and make it impactful for our patients. And so, maybe let's start right at the early stage of the cancer journey. And often cancer is a bit of a hard word or a bit of a big hit to the patients up front. So, I see it in a slightly different context. Maybe as a urologist, we're a bit upstream sometimes, and we see patients where it carries more weight than it ought to. In some cases, localized disease, non-aggressive cancers that really ought not to influence someone's life trajectory and yet carry this real burden of the word. And so I'm wondering, how do you guys approach it? How do you see it in your practices, dealing with the maybe societal stigma that comes with the idea of having cancer?
Well, I'll start off for that if you want. And the reason I feel like it's important, just as you said, to kind of think about cancers across the spectrum. So I see a lot of patients actually with localized prostate cancer. It's about half of my practice due to our multidisciplinary approach. And patients or people become cancer survivors from the moment of that C-word type of a diagnosis. And in their minds, I think it's not necessarily different if they have a low risk localized prostate cancer where they can engage in active surveillance and hopefully, be fine, or a non-muscle invasive bladder cancer where they know they're going to get, maybe just a TURBT or maybe some BCG and still be cured. To someone who's metastatic, at the beginning especially, it all feels the same, and every ache, every pain, everything that they experience can be attributed to this new thing in their life, this new really elephant in the room in many ways. Mm-hmm. So I think one of the most effective ways to kind of deal with this is not to say, oh, you shouldn't worry about that, because that really doesn't acknowledge the patient's feeling of dread when they kind of get that diagnosis, but explain how they can be monitored over time and explain how we can make sure that this will not impact their long-term longevity and the way that we'll make sure that we catch it if it can be caught. And that is just as important as helping somebody with metastatic disease or incurable disease to understand, hey, here's how we're going to take care of you. And yes, this may limit things, but we're going to be there with you each step of the way, and we're going to make that time good time. So each end of that spectrum is actually really important, and even though so different, in some ways really can be quite similar.
Yeah. It sounds a lot like level setting, right? Like helping people understand what their actual disease is. And I hear myself in the clinic saying the same thing over and over, which is like prostate cancer. Prostate cancer is not a disease. It's a number of diseases with wildly different phenotypes and behaviors. And so I'm wondering sort of what approaches the rest of you take to actually, apply that, great idea into your clinical interaction.
I agree with Alicia entirely. I think it's about sort of acknowledging the existential threat that each patient experiences, regardless of why they're coming in. You can calm a certain degree of anxiety with data, right? Like this is I never know for you, but these are patients like you. This is what we're working for. This is what I'm worried about. I think a lot of people come to that initial visit terrified, like they think I'm the absolute boogeyman because I'm connected to that diagnosis. And I think sometimes when they this is just an opportunity to build a connection and be someone who's going to be their guide in this journey. And that's kind of how I view myself. Like, I'm not a paternalistic old school doctor, I'm your guide. And so they leave knowing what the intent of our treatment is, knowing what the plan is, right? Like, the devil you don't know is so much worse is so much worse than the devil you do know. Like, it's just, they leave armed with a plan, and they leave armed with an ally. And I think that helps to ameliorate a lot of anxiety.
Yeah, and I think both of you made a lot of really important points. I will only add that these are often really multi-step and really multi-visit discussions, right? There's, I mean, for a new patient, we generally get an hour, right? Which is actually quite a bit of time compared to many other specialties and many other types of patients, right? But it's still really not enough, I find, really to address everything, right? Whether for patients with really like advanced metastatic disease, where you need to really address a lot of questions and symptoms and like treatment options, or even more involved discussions of patients with maybe earlier stage disease, where it's sort of understanding what the different options are and what really is ahead of them, right? But yeah, so for me, it often ends up being that the first visit is you really just sort of set the stage for what you then discuss, later, even if it's a phone call after the visit or a subsequent visit, right? I mean, but a lot of patients, you kind of, with more advanced disease, you have to start them on treatment soon or right away, or there's not a ton of time, but it's still important to I think do this often in a stepwise manner. So for that first visit I still try to outline at least a plan that what our first option would be, maybe if it's the frontline treatment or a clinical trial or something like that, and if that's not an option, what some other options would be. But then often it does require a follow-up discussion.
I totally agree.
And I was going to say, I also see it from both perspectives, and I agree. The comments are all excellent and very mindful, but yeah, it does take more than one visit, and it also takes more than one team member to go in there too, because even when I've mentioned things or I follow the physician in just to kind of sit down and let the dust settle a little bit and just be that calming presence and establishing that trust relationship that we need to, I think it just adds another layer to the visit, as well as gives them another sort of person to reach out to. And I may not appear to be the one making decisions at the first visit, but obviously, I want them to hear what was being said and get their initial thoughts, and sometimes just stop, because we are like word sentences, diarrhea sometimes when we're trying to get everything out, but just stop every once in a while and check in with the patient, like, what did you hear? And I think sometimes we're not always that good about allowing a little bit of silence. We feel we have to fill that time, but sometimes just giving them the 10 or 15 seconds, you might learn something, that's very pertinent. So I agree. It takes multiple visits, small little steps at a time, and just reassuring them that the plan is there, and I agree with the data and all that. So all very important things.
But thank you for reminding us of the multidisciplinary approach, because every visit, that first visit is, and everyone's clinic is different, but mine sounds like very much structured like yours, and this is a team approach, and I want you to meet me, and I want you to meet Katie, and I want you to meet Greta, because you're going to see us all, and we kind of manage you. And if you're only meeting one representative of the team, the next visit you'll be like, well, who the heck are you, right? So it has to be everybody, because we are a team.